But if we do understand the cause, we can use a word that we just don't use in mental health, and that's cure. Someone who works with me was doing Google searches and looking at how people search for mental health. And she said when people search for cancer, they use words like, how do I cure my cancer? When people search for any mental health diagnosis, nobody even uses the word cure. How do I manage my ADHD? How do I decrease side effects on this? How do I improve this? Nobody Googles, how do I cure?
So I'm thrilled to welcome the co-founder of IMMH, Dr. James Greenblatt, who's worked tirelessly to advance the field of integrative mental health and functional medicine psychiatry over his 35 years of clinical practice. In 2009, he co-founded IMMH with Dr. Shaw. So it's in large part thanks to him that we're all here now. I think he was the first speaker that I heard at IMMH in Chicago in 2011, and I was hooked. And since then, I've had the privilege of getting to know him personally and have followed his work closely, and it's an absolute honor to introduce him today. As a board-certified child and adolescent psychiatrist, Dr. Greenblatt is really working at the coalface of our mental health crisis with children and teens and has consistently promoted evidence-based methods, yielding more sustainable and better results to address our tremendous mental health crisis. After receiving his medical degree and completing his psychiatry residency at George Washington University, Dr. Greenblatt completed a fellowship in child and adolescent psychiatry at Johns Hopkins Medical School. He served as the chief medical officer at Walden Behavioral Care in Massachusetts for nearly 20 years and has been an assistant clinical professor of psychiatry at Tufts University School of Medicine and Dartmouth College Geisel School of Medicine. He's the author of 8 books, including the bestseller Finally Focused, the Breakthrough Natural Treatment Plan for ADHD. His updated edition of Answers to Anorexia was released in October 2021, and his newest book, Functional and Integrative Medicine for Antidepressant Withdrawal, is out now. He's the founder of Psychiatry Redefined, an online learning platform dedicated to an evidence-based personalized treatment model for mental illness. And we owe a huge debt of gratitude to Dr. Greenblatt for everything he's done in the field. And so I'm incredibly excited to welcome you, Dr. Greenblatt. Thank you so much for being here.
Thank you, Kirkland. It's always great to join you for your endeavors, and appreciate the revival of IMMH, and certainly in person. So thank you. And it's really great to be here again. It was many years ago when one of the reps at Great Plains at the time and I approached Dr. Shaw about trying to organize this material in a conference. And I think there might have been 50 people year one to 500 people. So it's great to be here. And as a child psychiatrist, I've really tried to kind of position my career as a bridge. I've been maintained a foot in traditional inpatient child psychiatry. So I'm seeing the most severe psychiatric patients admitted to psych hospitals. And I've had this world in an integrative functional medicine approach. And it was the outgrowth of IMMH that started Psychiatry Redefined, the platform now where I'm hoping to educate clinicians as best as we can. So I guess we're going to start with just what I did this past month, because it was pretty striking. So I got to do a presentation at a traditional psych program, Psych Congress, 2,000 traditional psychiatrists, and pretty overwhelmed with psychopharm booths. And if you've been to any psych conferences, you get cappuccinos and milkshakes and quite impressive exhibit halls. And then I went to the Iliad's conference in Boston a few weeks later. Well, I guess the punchline of the Psych Congress, I gave this talk on nutritional psychiatry. And I don't know, 400 or 500 people in the room, and people were fascinated. But all the questions were about themselves or their children. These psychiatrists couldn't understand what I was trying to articulate was for their patients. and changing their practice. And it was a little frustrating, but and then a few weeks later, I went to this Iliad's conference, and I was the guest of a father who I knew who lost his son to suicide from a Bartonella infection. And so I listened to the conference on Lyme, and he introduced me to two other parents who lost their young adults to suicide with, and they did brain biopsies with diagnosed infections, untreated, unaddressed by the mental health system. So, I mean, I've been talking about infections and mental health for years in psychiatry defined, but this wasn't intellectual, this was emotional. It was the most powerful hour of my career sitting with these four, they were all physicians who lost their children to suicide due to an infection that was never looked at by their providers. They had the resources to get the best psychiatric help, and nothing was done or even addressed. So everyone here, I know I'm preaching to the choir, is aware, and I'm just going to share some focus thoughts on this staggering increase in mental illness in our kids. And, you know, the numbers are just profound and frightening at the same time. So the CDC's new data, over 30% of adolescents seriously considered suicide in the past year. Not ideation, but seriously considered it. And so we take all this data, and that's why I titled this talk, Awareness is Not Enough. And we keep using this term crisis and epidemic. And I started getting real angry because I was tired of hearing and seeing these statistics about this crisis of mental health, because I'm not sure we have a new crisis. I've been in this field a long time, and I've seen horrible trauma and abuse and mental illness in kids for many, many years. And I think what has peaked and why it's so important that we are together and we're continuing this process is it's not a crisis, it is a crisis of our care, our mental health care, our model. And that's what we want to talk about. And this I don't have to spend a lot of time on, but we certainly can appreciate the asking a lot of questions, picking a diagnosis, picking a pill, and then the 10-minute med check. So symptomatic-based polypharmacy hasn't helped. The outcomes are atrocious. Relapse rates are high. The side effects of medicines are poor. And so we know there's a better way, and we have lots of different names for it. And we'll get to that, but it's pretty clear it all comes down to a model of understanding this clash or this dance, if you will, between genetics and environmental factors. And that clash, those biological changes, things happen. And genetics, metabolic, and brain activity, as you heard in the last speaker, so things happen. And nobody's looking at any of the underlying causes, but the model is there. And I've used this slide a lot because in the field, for all of you looking for a different approach, I spoke to someone this morning, a psychiatrist who said, I'm tired of the symptomatic-based approach. I'm looking to expand my knowledge. And then everyone gets stuck on these terms, integrative medicine or functional medicine. And they're slightly different in my mind, but we obviously need both, right? Integrative medicine and functional medicine looking at root causes. And I think we've all been bombarded with other names, from regenerative to restorative to anti-aging. We're all looking for a model based on science and based on understanding our patients. So what I want to spend most of today on is this nutritional lithium, and what I believe should be a diagnosis in our understanding of childhood mental illness, and that's called lithium deficiency syndrome. Never heard of it. It's never been written. It's never been discussed, but I think it's critical. So I want to kind of take you on this journey. Many of you know I've been talking about lithium for 35 plus years, but let's kind of do it again. Hopefully you learn something and begin to appreciate how powerful this micronutrient intervention could be for child mental health practice. Again, lithium is in the Earth's crust. It's in the rocks. It gets filtered through the water. And so it's in the groundwater, it's in the soil, and we get small amounts from our food. But I'm going to keep coming back to we probably get most of our lithium that we need for optimal brain function from our tap water. Now, if I said tap water again, everyone's going to shudder because nobody drinks tap water, right? So one of our concerns is this filtering out lithium and the use of bottled water over the past 40 years affecting lithium levels. So this is kind of the tour that I want to share with you, the clinical utility of low-dose lithium. And what I want to wrap it around is this symptom of irritability. And we can look at all these disorders, ADHD, disruptive mood dysregulation disorder, conduct disorder, autism, bipolar. Actually, a new study just came out. It was kind of humorous because it was like got major headlines within the past week, I think, said literally irritability in childhood associated with onset of bipolar disorder. I couldn't have asked for a more appropriate title for our presentation. So we're going to go through this. Alzheimer's is not quite child psychiatry, but you'll get a flavor for the clinical use of low-dose lithium. So let's begin this tour first with autism. So we're all powerfully aware of the increased incidence. It's sad when I hear people say it's just an increased awareness. I think it's clear to all of us that it's not. It's a profound genetic environmental struggle with a whole host of environmental insults. But rates are going up. And we know irritability is a major symptom. So what did our pharmaceutical buddies do? Well, they took an antipsychotic and they said, well, we know it doesn't treat autism, but why don't we do a little study sedating our autistic kids and get it proved for, guess what, the irritability associated with autistic kids. So a major antipsychotic is approved for just this symptom, irritability with autistic kids and children 5 to 16. And I can share with you multiple cases, and I know many in the audience can as well, with low-dose lithium completely eliminating the irritability associated with autism. And there's more research, not a lot. It's not something that we can say we have a lot of research on. We talk about low-dose lithium. But here we had hair samples from individual autism patients and mothers. The kids had lower lithium levels, and the mothers had much lower lithium levels. So I don't have a research. I have 30 plus years of clinical experience, and I know I've talked to many clinicians around the country looking at hair samples of individuals with lithium. It's pretty much oftentimes undetectable and support with low-dose lithium. Well, we'll come back to doses. So that's our autism study. Let's go to disruptive mood dysregulation disorder. Now, this is pretty interesting. For those of you who don't know, we didn't have this in the DSM-4, but at the time, people were seeing a lot of angry, disruptive, impulsive kids that were beyond what we would think of when we talked about ADHD. So they originally started calling them bipolar disorder, certainly in Massachusetts at all the Harvard hospitals. And they were putting these 5 and 6-year-olds on Depakote and Tegretol and high doses of lithium. And it was a nightmare for parents and families, and efficacies were not very good. So in the DSM-5, they said we can't call them bipolar, but there is pretty significant mood dysregulation. So they came up pretty much made up this symptom-based disorder, DMDD, and put in the DSM-5. And in the criteria, we get to use my favorite word, irritability. So they have these temper outbursts, verbally, behavioral, not appropriate for the situation, but the mood between temper outbursts is persistently irritable. Okay, and what do we do with these kids? Well, not too much different than we did for 20 years before. There's no guidelines, there's no approved pharmacotherapy. So depending on who you see, you're going to get a host of medications. They could be antidepressants, mood stabilizers, antipsychotics, alpha-2 agonists, stimulants. I mean, everyone has their own little program, if you will. And oftentimes, it's going to include multiple psychotropics. I will share with you my clinical experience and with colleagues around the country. This disruptive mood dysregulation disorder is almost, in my books, defined as this lithium deficiency syndrome. They respond to low-dose lithium. Now, in the functional medicine world, and if anyone knows my work, we are always looking at multiple biomarkers, objective testing. So I don't want to repeat what our colleagues have done with medicine, is that everybody who's has this symptom should get this nutritional supplement. So it's not that simple, but sometimes it can be, and certainly a component. Big part that we're going to talk about of understanding how to use nutritional lithium is understanding family history. I'll just share that piece now because many of our DMDD kids have family histories of aggression, anger, addiction, bipolar disorder, suicide attempts, or violence. And those are the individuals that are most likely to respond to nutritional lithium. So I learned this from Jonathan Wright 30 plus years ago. Didn't quite register at the time, but over these years, the family history is often the key. So they might present with this DMDD, irritable, angry, those kids that are most responsive to lithium. Again, family histories of addiction, bipolar, irritability, anger, violence, often best responders to lithium. Okay, let's keep going. ADHD and conduct disorder. Again, it's not necessarily our ADHD kids that are inattentive and can't pay attention. It would be our ADHD kids that have poor impulse control, disruptive, and more hyperactive. Our conduct disorder kids. Again, many of these kids have that family history that I presented. And the studies that I have, these are not nutritional lithium, just demonstrating that lithium can decrease aggression. So this was a prescription lithium for conduct disorder here. And here for criminals, we did get hair testing, 2,600, 20% had extremely low lithium. Violent criminals had little to no lithium stores. And I know Dr. Walsh talked about doing hair testing on criminals in the 70s, I think it was 70s, and then undetectable to low levels. And he couldn't get anyone to listen to him at the time. So he stopped pursuing it. But he does talk about these low lithium levels. And here, again, lithium carbonate, high doses, but a powerful intervention that the only reason they use the high doses because they didn't know about low doses, but kind of one of the more dramatic understandings when we think about lithium is this ability to reflect on consequences of behavior and mood. Whether it's an ADHD or bipolar or violent individual, they act impulsively without thinking. Lithium is the anti-impulsive nutrient that can provide the time to help them think. Okay, how about addiction? Again, something we've been talking about and using for many, many years. But now we have a couple studies. So this was a recent study by Dr. Gadd in New York City in a residential kind of eating disorder facility, 425 patients. And what he gave as low dose lithium was one pill of lithium carbonate. I believe it was 150 milligrams, and pretty significant results. They had treatment as usual, less medication, dramatically less benzos, less drugs, and compliance increase. So, in the completion of the program, 100%. So let's just take a minute to think about small amount, 150 milligrams of lithium, which translates, and we'll talk about this in a minute about clinical use. So 150 milligrams of lithium carbonate is only 28 milligrams of elemental lithium. So you can't do 1-to-1. So on a small amount of lithium, over 500 individuals in a residential treatment program for addiction, these were adults, completion rate improved by 100%. Every other variable got better. And then we think of the tragedies of our adolescents now, plagued by multiple addictions, whether it's marijuana, cocaine, or opiates, or anything else they can find. The devastation and the in addition to the public health implications is just profound. And again, small amount of lithium has been shown to be helpful. So I want to get back to low doses, because I think that is the kind of magic for our kids. And here, a group in Japan published in the Journal of Clinical Psychiatry looked at lithium levels in the drinking water. Okay. I shared with you that lithium is in the rocks, gets to our water, and is in our tap water. And here's 3,000 students. And if you were in a school with low lithium versus high lithium, there's dramatic difference in both depression and interpersonal violence. So higher lithium, it decreased depression and decreased interpersonal violence. Again, irritability, aggression with more lithium in the drinking water. Okay, it's pretty dramatic. And to expand this concept, and many of you heard me talk about the relationship between lithium in the drinking water and suicide risk. Now, we all can appreciate, often be overwhelmed with the suicide statistics. Again, the title, More Awareness, does not bring any improvement in rates. We have more screens, we have more testing, we have more drugs to treat depression, and our suicide rates continue to increase. We have no model that is shown to be effective. So we go to our drinking water, and these are studies that have been done around the globe looking at lithium in the drinking water. The first studies were done in the 1970s, and then a repeat in the 80s, published in 90 in Texas. So again, Texas is a big state. Remember, multiple samples of water, looking at lithium levels, and there is a inverse rate, higher lithium levels, lower suicide rate. So it wasn't just in Texas. These are the dates of published studies around the globe. Okay, well, let's go back. So there was only one negative study ever published, and that was in the UK. And we actually spoke to one of the authors who was able to articulate that it was a poorly done study. They didn't sample wide enough, and there wasn't a big difference in the country. So it is quite clear that this information is powerful. And then here's a couple of these kind of meta-analysis looking at over 3.7 million individuals. Okay, these are recent studies. Lithium in the drinking water, dose-dependent reduced risk of suicide mortality. And then here's Dr. Meeman, who is one of authors on the negative study, who said it shouldn't have been published, did this study looking at 415 studies with this same pretty profound conclusion when we think about it. Naturally occurring lithium in the drinking water have the potential to reduce suicide risk. Okay, so again, it's not one study. We're talking about hundreds of studies, millions of individuals. The research is indisputable. We also know, which I didn't develop slides for, is prescription lithium decreases suicide dramatically, right? We talk about rates decreasing 80, 100% lower for those individuals on lithium. Lithium carbonate is an anti-suicide molecule. Okay, but we're not talking about a medicine here. We're talking about a micronutrient that I'm afraid to say you can buy on Amazon. Okay, so we've had that the groundwater in lithium, okay, has affected, the early studies looked at psychiatric admissions and actually rapes and homicides, but all lower. And it's just kind of overwhelming when you think about the crisis, and I will use crisis here for our kind of spiraled suicide epidemic with no model of treatment. When we have a micronutrient that we have 50 years of research is anti-suicidal. And if any of you have sat across from a family, and I have many times, that have lost their child to suicide, you can appreciate the desperate need to find, one, biomarkers, and two, treatment alternatives. So the question that I've been trying to ask for 30 years that I'm quite clear is, do some patients have a lithium deficiency? And I will say yes. And do some patients have a genetically driven increased requirement for maintenance? And, you know, as a kind of originally got my interest in nutritional psychiatry with the orthomolecular world with Dr. Pauling and Hoffer, when I was actually in college before I went to medical school, you can appreciate the fact that we all have very different genetic requirements for micronutrients, whether it's vitamin D, which I now guess has gotten some good press about genetics and our vitamin D requirements, but we can do the work and look at the work of Roger Williams and his book, Biochemical Individuality, and understand it cuts across every micronutrient from vitamin A, E, and hopefully we can appreciate that lithium as an essential micronutrient has the same kind of concept of biochemical individuality. And this is a unpublished study, but this was a great work by nurse practitioner Jenny Reed, who gave us permission to, this was accepted for publication. So she looked at this calcium channel, a marker. It is one of the markers on the Genomind genetic test that we use for pharmacogenetic testing to look at both medication and some biomarker, MTHFR that I talked about. But this gene is always fascinating me. For years, I've always used both lithium, magnesium, and essential fatty acids. But what she was able to demonstrate, looking at those that had A allele, so one of the heterozygous SNPs, so impaired function of this, one of the genes for calcium channel blockers, that lithium was significant. So she used low dose lithium under 600 milligrams for 50 individuals with diagnosed depression, bipolar anxiety, and those with that SNP had better response to lithium. So here they're getting closer to looking at some genetic variants, and this is just a simple cheek swab of those that might respond better. So these are MTHFR variants. So let's just kind of regroup for a minute and try to put this into some clinical context for everybody. Nutritional lithium, a nutrient that's been with us from day one, essential for brain function. The mechanisms of action, I'll go over in a minute, but they're just literally hundreds. But it has a role. Bipolar disorder, more so bipolar 2. I don't recommend nutritional lithium for bipolar 1 unless someone is stabilized. Addiction, anxiety, aggression, irritability, impulsivity. I've had patients road rage, depression, ADHD. I actually had someone who came, I'd call it office rage. His wife dragged him in. I was treating their kid, and she dragged him in to see me, and I was late. I was 15 minutes late. And he not only was really abusive and angry to the office staff, but he spent his entire session yelling at me how I don't know how to run an office and how could I be late. And it was both upsetting and a little frightening. He was angry. But, over a couple months, he happened to not only apologize, but one of the best responses to, and he came in for road rage, his wife brought him in, because 5 milligrams of lithium completely eliminated that symptom that was disruptive. So here's some of our diagnoses, sorry. And I want to try to think of this word as a functional lithium deficiency. So we can really kind of go beyond for a minute. If you wanted to really delve into the world of lithium, you can continue from glaucoma to antiviral properties to cancer. We have a full day, 2-day conference actually, and a couple of people spoke on cancer and Parkinson's and ALS. I mean, the literature is quite so we will get to clinical, how to use it, but how does it work? It's both fascinating and complicated, and I can't begin to say that I understand it. I think the thoughts that first come to my head when we think of the how lithium works, you can think of first neurotransmitters. Lithium decreases glutamate and dopamine, some of our activating, and lithium increases serotonin and GABA. Okay, lithium increases GABA and serotonin, decreases glutamate and dopamine. So that's calming, just thinking about it. And then if you go a step further into the kind of cellular biology, lithium has anti-inflammatory and antioxidant properties. And sometimes when I go through this, it kind of sounds like too good to be true, but go into the literature if it doesn't make sense. But there's microglial activation decrease, glutamate exotoxicity decrease, oxidative stress and inflammation decrease. The work on Alzheimer's is extensive, probably more significant than the work on the anti-suicide. So the beta amyloid and the tau proteins decrease. And the mechanism is likely inhibiting this GSK3 enzyme. So there are biotech companies looking at developing medications that inhibit GSK3 because that is the secret mechanism to curing some of our neuropsychiatric illnesses, right? Literally, startups, multi-million-dollar companies looking for GSK3 inhibitors, and lithium is a GSK3 inhibitor. Let's take a minute now and talk about kind of dosages for a minute. So Lithium orotate. There is a community among traditional psychiatrists talking about the horrors and dangers of it. We've had a Pure Encapsulations commissioned a study, a toxicology study on lithium orotate, which was presented a couple of years ago. And there's really any of the concerns around lithium orotate are not grounded in science. Some people quote a rat study that was done 50 years ago that was the amount of lithium that no human could ever take. So it's simple, it's safe. The dosages I use are anywhere from 1 milligram to 30 milligrams of lithium orotate. I used to start everyone at 5 milligrams. As more and more people use lithium, I start everyone at 2 milligrams, 1 or 2 milligrams. One, because people are scared of lithium. They think of it as a pharmaceutical, and it's been so helpful that I just want someone not to have a side effect. And two, the potential side effects that I've seen are some people feeling spacey, and one doctor told me she felt too calm and didn't like the feeling. I've seen headaches as well. But my concern over the past few years is so many companies now producing or selling lithium without much testing. We really don't know what's in any of these over-the-counter supplements, that I've just seen more side effects. So where you get it's important. Trying to start off with a low dose is important. But the other clinical indicators, I just want to kind of share or review. Some of it we talked about a lot, and you're tired of hearing me use the term irritability, but those are our clinical symptoms. We do look at trace mineral hair test. Okay. When I started my practice 100 years ago, I maybe 25% undetectable lithium in the children that I was seeing. I'm just making it up, but a number under 50. Now, last 5 years, I'm seeing probably 75% undetectable lithium. And again, those are people walking into a psychiatric practice. I believe some of it is due to our bottled water. Some of it's probably due to lots of other toxins in the environment and absorption, but I'm just seeing more undetectable lithium. So it is a nice marker. Now, there's no blood test that makes any sense to look at whether you would want to use nutritional lithium, because nobody should have a blood level of lithium. So don't waste your time drawing it. So we look at clinical symptoms. I look at trace mineral hair test. And as I described, I look at family history. Please go back 3 generations. If you ask parents, they might not have had any significant mood disorders, addiction, aggression. But if you get to the grandparents, the aunts or uncles, oh, Johnny was in jail, Aunt Anne was in, prison. Do 3 generations family history. Things will scream out, and you'll begin to see that pattern of the individuals that are kind of one in our mental health system, but 2 lithium responsive. Okay. Now I use lithium regardless of the trace mineral hair test. Okay. Someone might have adequate levels in the hair, but it doesn't mean that I wouldn't use lithium, nutritional lithium, before I would a prescription, because use the term nutraceutical. So we can get a nutraceutical effect. The same that we might use, higher doses of magnesium or other amino acids or N-acetylcysteine. So there's a nutraceutical effect. So testing helps, certainly looking across from a parent and showing the undetectable lithium, but I still would use lithium. Family history is helpful and clinical symptoms helpful. And again, I started this discussion, just want to kind of continue a bit. So lithium carbonate, right? 150 milligrams of lithium carbonate has 28 milligrams of lithium. Lithium orotate, you have to read the label. There are some companies that you don't know if they're measuring the lithium and orotate or just the elemental lithium. From some of the, more the supplement companies, that sell to physicians, have a higher quality assurance, and most of those both are checked, and they're using the amount of elemental lithium. Pure encapsulations that we use is amount of elemental lithium. So again, the fight among traditional psychiatrists versus people saying orotate is better. I don't think anyone is better than the other. I think it's important to just look at the amount of elemental lithium. Clinically, in my early work, I used to go up to 40 milligrams of orotate. Now I just stop at 30 because 150 milligrams of carbonate is so simple. Insurance covers it. And that's where I get 28 milligrams of lithium. So I don't think this fight is worth it. Think about the amount of elemental lithium. And, I just stuck this in because over my career, I've gotten more of these thank you notes, emails from parents and spouses, and et cetera, about adding this inexpensive, powerful nutritional supplement. Again, we can't forget our functional medicine testing, but adding nutritional lithium is powerful. So I mentioned lithium enough that I just wanted to share with you that you have to pursue and read about some of the data on lithium and dementia. It's profound, and as much as we can certainly appreciate the Bredesen protocol and all the incredible work that he and his team has done, that adding lithium can be a tremendous adjunct to that kind of individual biomarker testing. So, my work over these years is trying to help people understand, mental illness as a reflection of multiple errors. We often can get stuck in our community of thinking we have the answer. Some years it's gluten, other years it's a new liposomal supplement, but either way, it's usually not one thing. But if we do understand the cause, we can use a word that we just don't use in mental health, and that's cure. Someone who works with me was doing Google searches and looking at how people search for mental health. And she said when people search for cancer, they use words like, how do I cure my cancer? When people search for any mental health diagnosis, nobody even uses the word cure. How do I manage my ADHD? How do I decrease side effects on this? How do I improve this? Nobody Googles, how do I cure? And a functional psychiatry model really can understand that concept. And I know everyone in this audience can appreciate that. So I'll kind of leave you there. This is kind of the work that came out of starting Psychiatry Defines, our fellowship. It's a 2-year program where we will kind of help train, individuals who want the information.
Incredibly grateful for Dr. Greenblatt, the co-founder of IMMH, and look forward to seeing you over the years and, supporting your amazing work. So thank you.